Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes with another classic clinical presentation for you. If you like this series, it would really help if you like and subscribe to Medical Education in Minutes on YouTube. Now let's meet Kelly Kramper. Kelly Kramper is a 28-year-old healthy female who is 37 weeks pregnant, and she is having her baby shower today. She has no medical problems and has had no problems with this pregnancy. Unfortunately, on her way home, she was struck from behind at a stoplight by a truck going approximately 20 miles per hour. She had her seatbelt on and her airbag deployed. She injured her forehead and her body was jolted by the collision. Immediately afterward, she started having severe cramping abdominal pain. The driver of the other vehicle immediately called 911. The ambulance rushed her to the hospital. They communicated with the hospital that they had a 37-week pregnant female status post MVC who is now having severe abdominal cramping. Please help my baby. This healthy 28-year-old female, again 37 weeks pregnant, had a motor vehicle collision with minor head trauma, likely because her airbag deployed. She now has severe cramping abdominal pain and bright red vaginal bleeding. The examination was completed, and it was significant for a blood pressure of 100/70, a heart rate of 110, respiratory rate of 22, and she was afebrile. She had an abrasion on her head from the airbag. She had a completely normal neurologic examination. Her neck was non-tender and fully mobile without pain. She had normal cardiopulmonary exam, but significantly, she had a tender, rigid uterus and bright red vaginal bleeding. The ultrasound shows the baby's heart rate to be 100, which is quite slow, and a large retroplacental hematoma. The doctor told the nurse to call the obstetrics unit, and he quickly transported the patient. He gave a report to the obstetrician, who immediately evaluated the patient. She already arranged an operating room for emergent delivery. So, what happened here? Well, this is called Abruptio Placentae, or placental abruption. This is a premature, partial, or complete separation of the placenta from the uterus. The cause is anything that compromises the maternal blood vessels in the decidua basalis on the maternal side of the placenta. Risk factors include the Hibhaya, had it before, had it again phenomenon. Once someone has had a baby and had an abruption, there is a risk that the next child will have the same. Age greater than 40 years old is also a risk factor. Hypertension increases the risk 5 times. Cocaine and or smoking cigarettes increases the risk 4 times, and this is due to vasoconstriction. Polyhydramnios, which is a lot of amniotic fluid, more than is usual, can also cause shearing forces that lead to abruptio placenta. In our patient's case, it was trauma. Trauma can induce abruptio placenta by shearing forces due to the impact. The presentation is typically painful contractions with bright red vaginal bleeding. On exam, you'll see a very tender and rigid uterus. The action you need to take is immediate delivery. The only circumstances where this does not happen is when the bleeding is minor, the abruption is small, and the baby is premature. When the doctor returns, he is beginning his charting, and he checks the patient's laboratory studies. Chemistry normal, slight anemia, normal coags, and normal urinalysis. Hours later, the patient returns from the OR, and she and her baby seem to be doing well, although the mother quite literally feels like she was run over by a truck. The next day, she felt something warm on her face. She realized she is bleeding from that forehead abrasion. A bit weird. Then she noticed painless bleeding from her vagina and from her surgical scar. So she called the nurse. The very astute nurse sees the bleeding from the head, IV site, surgical wound, and vagina and is immediately concerned that the patient is in DIC. She is hypotensive and tachycardic. He immediately calls the obstetrician and draws the blood tests necessary to evaluate for disseminated intravascular coagulation. Disseminated intravascular coagulation. The mechanism. This is a serious complication where the premature separation of the placenta causes tissue factor activation in the mother's bloodstream. Initially, you will see widespread microvascular clotting, ultimately resulting in consumption of the normal clotting factors and platelets, followed by bleeding. In order to truly understand DIC, I think we will need to take a deep dive into normal hemostasis and then discuss this pathologic state. We will begin with primary hemostasis. This is a diagram of a blood vessel illustrating its endothelium in red, underlying connective tissue in blue, and smooth muscle in brown. With blood vessel injury, all three layers may be injured. Endothelin is released from damaged endothelial cells. This causes the smooth muscle to contract, closing the gap so that the bleeding is minimized. I mean, it's pretty critical that you close the hole when you have a ruptured blood vessel. This also gives you a sense why pressure helps to stop bleeding. It stops blood loss and allows the coagulation pathway to work. When the endothelium is damaged, von Willebrand's factor is exposed. Platelets are activated and attached to the von Willebrand's factor by way of the glycoprotein 1b. These platelets call in more platelets. The activated platelets secrete glycoproteins that attract more activated platelets. More activated platelets adhere to the established platelets with the glycoprotein 2b3a. Now we have a sticky clot closing up the injury. But this clot is fragile. But this is the end of primary hemostasis. Now secondary hemostasis begins. Most clotting factors are made in the liver, and they circulate inactive in the blood. The exceptions include factor VIII, which is made by endothelial cells, and factor III, or tissue factor, which is made by fibroblasts. Let's start with the intrinsic pathway, which on laboratory studies is represented by PTT. The sticky blood is negatively charged, and it attracts factor 12, or Hogmann factor, and activates it. This is the initiation of the intrinsic coagulation cascade. Activated factor 12 activates factor 11, then activated factor 11 activates factor 9. Factor 8 interacts with factor 9 and calcium, and this activates factor 10. Activated factor 10 reacts with factors 5, 3, and calcium. This group creates the prothrombin activator that converts prothrombin into thrombin. Thrombin activates circulating fibrinogen, which is a soluble circulating protein, and creates an insoluble fibrin chain, which is more jelly-like. Thrombin also activates factor 13, the fibrin stabilizer. Factor 13 cross-links the fibrin, creating the jelly-like fibrin mesh, which overlays the platelet plug, thereby stabilizing it. If a medium-sized vessel, let's say a coronary artery in the case of a myocardial infarction, or the middle cerebral artery in stroke, is completely obstructed, it leads to distal ischemia and death of tissue. The immediate treatment is dissolution or removal of the clot. In the case of DIC, clotting occurs diffusely in the microcirculation. It can lead to partial obstruction of many small vessels. Red cells, red blood cells that is, get hung up on the clots and break apart, leading to formation of schistocytes, which are basically chewed up red blood cells that may lead to intravascular hemolytic anemia. While all the rest of this is going on, there is clot retraction and vessel repair going on too. Actin and myosin, contractile proteins within the platelets, pull the endothelial cells together, again closing the hole. Platelets, endothelial cells, and fibroblasts secrete platelet-derived growth factor, or PDGF. Platelet-derived growth factor causes mitosis of smooth muscle cells and patches the connective tissue. Platelets and endothelial cells also secrete vascular endothelial growth factor, VEGF, which regenerates the new endothelial lining. There are two arms to the coagulation pathway that intersect at the common coagulation pathway. So far, we have discussed the intrinsic pathway, which is initiated by damage to a blood vessel. The intrinsic pathway is represented by the blood test PTT. The extrinsic pathway is what is activated in our patient. It is initiated by the release of tissue factor 3 by fibroblasts. Factor 3, also called tissue factor, activates factor 7, which activates factor 10, just like in the extrinsic pathway. The function of the extrinsic pathway is reflected by the PT blood test. Note here that thrombin activates fibrin to form stable clots, but it also will stimulate tissue plasminogen activator to be released on the endothelial cell surface. This ultimately activates plasminogen, which activates plasmin or converts to plasmin, which starts to break down clots. If you have a hard time remembering the difference, some clever person suggested this memory tool. You play table tennis, PTT, inside or intrinsically. You play tennis, PT, outside or extrinsically. Tissue factor may be released due to physical injury of the vessel, but it is also released in the case of inflammation or infection. In our patient, the damage to the vessels in the maternal decidua basalis of the placenta and or a small amount of amniotic fluid embolism during abruption caused the release of tissue factor 3 and initiated the extrinsic coagulation pathway. In hemostasis, there must be a balance. You don't want obstructed blood vessels or clots all over your body. Therefore, as soon as clots are made, they're going to need to be broken down. Build it up, fix it, and break it down is the name of the game here. and fibrinolysis is next. The cell membrane protein called tissue plasminogen activator is located on the endothelial cells. It converts circulating plasminogen into plasmin, which chews up the fibrin and breaks down the clot. The same thrombin that promotes clotting also triggers the release of the tissue plasminogen activator in anticipation of clot breakdown after the clot is formed. Plasmin chews up the fibrin and the clots dissolve, releasing fibrinogen and D-dimer into the circulation. Our patient is bleeding from her surgical site, vagina, IV site, and her forehead abrasion. She is suffering from DIC. DIC is disseminated intravascular coagulation. The trigger is the release of tissue factor or factor 3. This can be caused by vessel injury, infection, or inflammation. This activates the coagulation cascade, including platelets and coagulation factors, which ultimately result in disseminated microthrombi. Red blood cells can be sheared, resulting in schistocytes or chewed up red blood cells. Anemia may be the result. This goes on all over the body, and the components of coagulation get used up, and this leads to bleeding. The consumption of components of coagulation. You will see a platelet count, which is typically very low, a bleeding time, which is increased. The PT is high, showing you what's going on in the extrinsic coagulation pathway. But the entire coagulation pathway is ultimately involved, and PTT is also high. D-dimer is high. This is a clot breakdown product. Fibrinogen degradation products are also quite high. These are the clot breakdown products. Fibrinogen is initially released, so it may bump up a little bit after all the clotting. But ultimately, when you have the signs and symptoms of disseminated intravascular coagulation, fibrinogen levels are typically low. This is a thrombohemorrhagic disorder like TTP, the HELP syndrome, and hemolytic uremic syndrome. Remember, the nurse sent the labs? Here are her labs now. Her hemoglobin has dropped to 7. Her platelet count is 90,000. Her PT is 16 and her PTT is 60. Her fibrinogen level is 90 and the FDP is 30. Her D-dimer is 1500. The primary hemostasis is affected by these low platelets, and secondary hemostasis is clearly effective, shown by the high PT-PTT. The treatment of DIC, most importantly, is to identify the cause and treat the cause. Well, at this point, the baby and the placenta are out. Then you need to replace the losses. Anemia is fixed by transfusing packed red blood cells. Platelets can also be transfused. The factors that have been eaten up can be replaced by fresh frozen plasma. Fibrinogen and other factors can be replaced with cryoprecipitate. Tranexamic acid, or TXA, is an antifibrinolytic, which stabilizes clots. People have seen some success with the addition of this medication in more extreme cases. Prothrombin complex concentrate, or PCC, is also used for severe bleeding, but this is contraindicated in DIC. Mortality from DIC in obstetrics is about 10 to 15%. All right, let's check in on Kelly and Andrew Kramper. Kelly and Andrew are now doing well. thank you to all the healthcare workers that saved my life. Thank you so much for learning with me. If you appreciate these classic clinical presentations on YouTube, please like and subscribe. It would really help me continue to post this content. Being a medical professional is the best job ever. You can use your knowledge to save people's lives. So keep studying, and I hope to see you soon.